treating sex and pornography addiction with Michael Iden.
So for today, I'm going to do my best to kind of give you all a sense of where we're at diagnostically when it comes to try and assess for something like a sex or pornography addiction. And then I will talk about some of the development of a sex addiction and kind of what makes up someone who has a sex and pornography addiction. My practice and my experience is definitely heavy on the attachment theory, polyvagal theory, kind of trauma-informed model of addiction development. So you're going to get my flavor of that through the presentation today, and I'm going to do my best to give some examples of how sex and pornography addiction can start out as a means of regulating affect, especially for those of us who might grow up in a chaotic or dysfunctional family system where affect regulation is difficult, or I might be alone in my attempts to do that. I'll talk about how sex and pornography and masturbation, fantasy can become a solution in that space. And then in the second half of the presentation, I'm going to do my best to give a variety of different treatment interventions, both that can be used on an individual or a group level. If you're working with folks individually or working in groups. I'm also going to talk briefly about how to have context for working with couples relationally who come in under the auspices of sex or pornography addiction, because 99% of the families that I've treated for sex addiction, they're coming in as a result of a spouse or partner just making some kind of a discovery of the sexual acting out, and then that is the driver into treatment. There's a few, it's very rare that folks come in of their own volition or not partnered. Does happen, but a little more rare. All right, so just to start to provide a little bit of definition for what is sex addiction, this is a quote directly from some 12-step literature from a fellowship called Sex Addicts Anonymous, which is one of the S fellowships or recovery fellowships for sex and pornography addiction. Addictive sexual behavior, acting out behavior, we sometimes call it, leads to feelings of shame and depression. It has the effect of masking, covering up, or numbing feelings. And it leads to isolation and a complete loss of control. Healthy sexual behavior, on the other hand, is characterized by mutual respect, a sense of clarity about feelings and communication, joyfulness, and genuine intimacy. It tends to make people feel emotionally and physically safe. So in that definition, they kind of hit a couple different classic diagnostic criteria for addiction. They talk about loss of control. They talk about regulating affect or changing my mood with the behavior. They talk about the cycle of guilt, shame, and despair immediately after the behavior, similar to drug and alcohol addiction. What I also like is they make some attempt in a not too rigid way to try and define what healthy sexuality is, which is something that we'll come back to throughout the presentation today, not as I'm going to pretend to know exactly what is the exact right criteria for healthy sexuality, but I'm going to do my best to give you all a sense of how I attempt to help clients define that for themselves and provide some kind of re-education with their sexual lives. Simpler definition for sex addiction is that it's an escalating pattern of out-of-control sexual behavior with an inability to stop despite negative social, legal, financial, occupational, or relational consequences. This kind of definition, if you're familiar at all with substance use disorder or problem gambling, fits very much within that addiction framework. A definition of sex addiction that I find is really accessible for a lot of clients and distills it down into oftentimes what sex addiction is really about is that sex addiction is a compensating behavior for attachment failure. Then when it comes to sex addiction, really what we're talking about is a failure to bond effectively. And in my attempts to maybe get little pieces of my attachment needs met, I compulsively steal little moments of intimacy or sexual affirmation repeatedly. And as we look in someone's origins or the origin story of their sex addiction, oftentimes we'll find some form of attachment failure, some space where I was not able to really securely bond to the people ideally that I would have relied on for help, like my caregivers or my parents. I'll talk about the actual diagnosis information that we have when it comes to anything like the DSM or the ICD-11, but up until a few years ago, there was not an official diagnosis in the DSM that really captures accurately sex addiction. So there's a couple of different assessments and tools that those of us who treat sex addiction have been using, and it's moving now in a direction where the next iteration of the DSM will have a more substantial diagnosis in this area. But what I found works very well is the same DSM criteria, those same 10 addiction criteria that's used for substance use disorder really fits for sex addiction. In many ways, the reason for that being that sex addiction is more about addiction than it is about sex. Sex is the means or the vehicle to achieve the change in my affect, to achieve this change in euphoria. But it's fits within an addictive pattern. It's not unique to sex in that way. There's a couple of different tools that I would recommend that are easy to find. One is called the Pathos, which is a simple screen. So it's like, hey, if you ask some of these questions to your client and they endorse them positively, there's a good indicator that it'd be helpful to explore that more robustly with some interview questions and more thorough assessment for sex addiction. There's also something called the Sex Addiction Screening Test, or the SAST, which is a 20-item questionnaire that someone can use, again, as a little further exploration of sex addiction. There's also an assessment called the SDI, or the Sexual Dependency Inventory, which is a battery of about 8 different subtests. It's similar in some ways to the MMPI, in that you're going to get a lot of information that tells you about this person's attachment style. It's going to go into both their behavioral patterns and their preoccupation or their fantasy patterns. It's going to get into how they experience the consequences of their addiction, both affectively or spiritually, financially, legally, that sort of stuff. That at this moment, the SDI is only available to the trained CSATs, but these other two are available for free online. And where we are right now is the ICD-11 included something called compulsive sexual behavior disorder. And these are the criteria that they've listed, these 5 criteria on the right. And as we look at these, repetitive sexual behaviors become primary focus of attention, generate negative consequences, repeated efforts to stop that fail. They're virtually identical to those 10 addiction criteria that, again, if you're working in addictions, you're already familiar with. They just packaged them a little bit differently. At the moment, it looks like they're going to place this under impulse control disorders, which is what they did with problem gambling before the DSM-5, and they moved it under the addiction category. My hope is that they do the same with this. I think it would be a misstep to place this under impulse control disorder. And what they do include that I really like, though, is that this piece around moral conflict about behavior or orientation is a rule out. So what this is getting at, and why this matters, is that because I work in sex addiction treatment, I get lots of calls from people who aren't sex addicts, but maybe come from a religious or a faith background that gives them certain messaging about different elements of sexual behavior or pornography, and some of their current behavior is in conflict with the belief system of their group. That in and of itself does not constitute addiction. So that will happen where folks will try and get into 12-step programs, or they'll try and get in with an addiction therapist to treat what is an addiction, which might be that I am in a faith system, again, that's maybe has lots of homophobia and isn't accepting of someone who's gay or bi. And so my sexual behavior connected to my orientation might be outside that system. And I might attempt to use an addiction model to, quote, treat that. And that's conversion therapy. That's not something that I do. It's illegal. And it's really important that we're able to kind of tease that out with clients, that this isn't just about a moral incongruence. This is about a pattern of behavior that throws my life out of balance and that I experience like real compulsion with. It's a little bit fuzzy. This is the pathos, and the pathos is just an acronym that uses those terms there on the left. Hopeful that you all can still read those, but if you just Google pathos, you'll be able to find it pretty quickly. But it asks questions, do you often find yourself preoccupied with sexual thoughts? Do you hide some of your behavior from others? Have you sought therapy in the past for sexual behavior you didn't like? So, even if someone endorses all of these in the positive, that doesn't mean they're a sex addict, but it is a good indicator that you should explore it further. Because in and of themselves, some of these questions, has anyone been hurt emotionally because of your sexual behaviors? There's a whole host of different activities or situations where that could be true. It doesn't have anything to do with sex addiction, but it's a good kind of starting point with clients. And if nothing else, are some good basic questions to build into your initial like biopsychosocial assessment when you first meet someone and you're working in therapy. Or if you're working in a different setting, like a more structured treatment setting, residential or intensive outpatient, you might add them into your intake paperwork. These are the questions connected to the sex addiction screening test, or the SAST. And as you look through some of these, you'll see things like, have you attempted to stop some parts of your sexual activity? If you felt degraded by your sexual behaviors, do you feel controlled by your sexual desire? So if I'm working with a client and they come in under the auspices of sex addiction, or maybe they don't, and I ask them questions and I start to get a sense there might be some compulsion on board, I will, hand them a copy of this, or send it to them online. You can find it for free online. The clinical cutoff with this, there's 20 questions. If someone endorses 6 or more, it's likely that they are sex addicted or on the spectrum of sex addiction. If they endorse 6 or less, chances are they probably aren't sex addicted. So again, it's just a way to kind of move in the direction of more formal diagnosis. What I've also found is that these questions and the answers to those can be really good topics to explore further, even if it isn't necessarily connected to a formal diagnosis or full criteria for a sex addiction. They also include some questions here that are going to get at sexual trauma or abuse. And what the data suggests is that 97% of sex addicts endorse in the positive that they've experienced some kind of traumatic event in their lifetime. And as I'm sure you all can assume, for the vast majority of the people, that's not going to be a one-off experience. There's going to be many. I talked a little bit about this moral incongruence piece about what sex addiction isn't. Some other things I've run into commonly is there's also folks who might have experienced a lot of infidelity in their relationships, or cheat often, and maybe have even multiple affair partners and still not necessarily be sex addicted. They might fit more into this category of someone who is very sexually entitled and presents more with kind of a narcissistic personality structure, where they might engage in a lot of gaslighting and crazy making and blame shifting with their partner when their partner discovers that there's some kind of an affair or acting out outside of the relationship. That cluster of behaviors is pretty common with sex addicts who don't necessarily meet criteria for a narcissistic personality disorder, but in the throes of active addiction, they present narcissistically. That's not uncommon whatsoever. The kind of a way to manage that clinically is, once we get someone into some abstinence from their sexual behaviors and into a recovery pattern and into therapy, we should probably see that narcissistic piece drop. And what will emerge is pretty intense shame and regret, typically. If you don't see that, and as we look through those DSM criteria for addiction, if we're not really seeing the buildup of tolerance, we're not really seeing withdrawal after the period when sex is taken off the table for an amount of time, then you might be working with someone who's really more sexually entitled and doesn't necessarily fit an addiction profile, and the treatment is different. Another thing to be really clear about is that sex addiction recovery or sex addiction treatment does not do anything in the way or attempt to change someone's fetishes or what might be a paraphilic interest or a disorder. Paraphilic interest or disorder could be anything from voyeurism to frauderism to exhibitionism. Sex addiction is not going to, or sex addiction treatment is not going to change your arousal template or the kind of the blueprint for what you find sexually interesting, arousing, and exciting. And it's not going to change a fetish. Treatment for a fetish is acceptance. Acceptance and maybe we're looking at how to integrate it into your life effectively within your current relationship or potentially in a new one. But I just want to be really clear that sex addiction treatment is not a model that attempts to or would be successful in changing a fetish. All right. So I'm going to start with this case example, and this is a real case or a collection of real cases. Of course, I've changed the names to protect folks' confidentiality. And so I'll share this with you. This is Brian. Brian and his partner present to therapy reporting that he's had some trouble with infidelity. That's kind of the initial context that's given over the phone to make the appointment. Brian's partner discovered his browser history, noticed money missing from their joint accounts, and recently tested positive for an STD, which she learned was shared with her from Brian. Brian reports that the following behavioral issues to the therapist. Brian's been using dating apps to find anonymous sex 3 to 4 times a week for the past 5 years and watches between 10 and 15 hours of internet pornography a week. Brian also frequents pornographic bookstores and has had sexual experiences with men 3 times in the past 6 months. Brian reports an intense amount of distress related to these experiences and is now questioning what they mean. Brian's partner is having a hard time digesting this new discovery and swings between anger and sadness rapidly during the session. Brian appears extremely remorseful for his actions and is desperate to get on the mend with his partner and understand his behavior. So for someone who has what we would call like a conquest sex addiction or more classic sex addiction, that implies that they're having lots of sex with other people. So Brian kind of fits more that category. So we're seeing that he's pretty compulsively on a regular basis seeking anonymous sex with others. He's also going into bookstores and having higher risk sex with other men. This element of heterosexual men having sex or sexual experiences with other men is not uncommon in this space. There's a bunch of different reasons for that. One, on the surface, is that if a man is seeking to have anonymous sex outside of relationship, he is more likely to find another man that is also willing to be sexual in that context than he is to find another woman, typically by the numbers. And if he frequents these kinds of spaces, like bookstores that might have peep shows or back rooms and that kind of thing, he's more likely to find men there looking for sex than he is women. And so as the addiction progresses, it's not uncommon that someone will go outside of the bounds of their sexual orientation to continue to compulsively pursue the behavior, which I bring up because that's a really simple way to highlight the idea that sex addiction is more about addiction than it is about sex. A few other things about this example. It's very important if someone's coming into your office talking about sex addiction and you learn that there has been any kind of a pattern of having sex with other people outside the relationship that their partner, if they're in a monogamous relationship, was not aware of. Imperative that everybody gets an STD test, full panel STD test. Physical safety is super important. Oftentimes partners have had very little information, or if they have been given information, it's been dribbled out very slowly over time and probably is not full and accurate in its picture of what's been going on. So for their safety, it's super important to start with that. And if you're working with an individual and they mention having a sex addiction and they're in a relationship, it's imperative that they get tested and make that disclosure to their partner. It's also really common that there is some kind of a financial betrayal that's part of the pattern where money has been moved to different accounts or new credit cards have been set up or there's cash set aside for sexual acting out purposes. So it's important to try and get into some transparency around that early on. I'll also just acknowledge that interpersonal betrayal, being betrayed and having trust broken, with our significant other is, for most people, what might be the most traumatic event of their lifetime. And it is a surefire way to fire up all of their unresolved attachment issues or unresolved trauma that hasn't been dealt with yet. It's going to all come on board at once, typically. Because this relationship that I've chosen as an adult likely started under the auspices of safety and intimacy and trust. And when that has been pulled out from underneath of you, it's extremely, extremely dysregulating and destabilizing. So you should expect that people are going to come in a pretty intense crisis on the onset of treatment for sex addiction. So I'll talk more specifically about the model that I and other CSATs use and how I was trained to try and meet folks, oftentimes couples, in the space of how do we operate from a place of respect and care and empathy for both of you right here, right now, and how can we set up a treatment trajectory that's going to be cognizant of the differences. It's more of a PTSD treatment model with the partners and more of an addiction model on the front end with the acting out partners. So as we peel back the layers a little bit with Brian, this is kind of the brief backstory with him. Brian's a 40-year-old male. His parents divorced at 4 years old, and his mother abruptly exited his life at that time. Brian's father worked multiple jobs and was rarely home, leaving Brian to take care of his younger brother. Brian was introduced to pornography at age 11 by some friends in the neighborhood. At age 12, Brian was sexually abused by a 17-year-old female babysitter. At this time, he began stealing pornographic magazines from local stores and using them to masturbate. So there's a couple kind of common elements of the development of a sex addiction in this example. Not to be prescriptive and say this is always the case, but there you can see parents divorced at 4, mom abruptly exits life. So Brian experienced a pretty significant abandonment wound with his mom. And dad's working multiple jobs to kind of make ends meet, being a single parent, now having 2 children that he's taking care of. So Brian is elevated to more of a parental role very early and experiences a lot of that false empowerment in his system. So his childhood ends here at about 4. And because of the impact of the abandonment, as we know, once that initial heavy trauma comes on board, emotional development pretty much freezes there in time. That's definitely what was true for Brian. And then typically short after, if I'm in a space where my parents and caregivers aren't available to me as a way to regulate my distress, to deal with the pain of life, I have to do that on my own in some way. Brian quickly found porn. He was exposed at age 11. The average age of initial onset of pornography exposure in the US is 10 years old. And that data is a little bit older. I haven't seen a national survey that's been updated since, or I would use a different figure. My hunch is that age is younger than 10 now. And that's the average, which means that there's plenty of kids who get exposed before 10. And so, but as we explore this history with Brian, he was exposed to porn through his friends. So watching pornography and masturbating was a kind of a core part of how he associated bonds with other men or his peers. And then he has this experience with a female babysitter, another person who's in a power situation with him that becomes sexualized. So not only is Brian already in this kind of parentified role where he is not really getting a lot of support from mom and dad, he also has what could be another attachment relationship with his babysitter sexualized. So you can start to see how easy it would become for Brian's entire life and his view of relationships altogether to become very sexualized and erotic. All right. So I mentioned earlier the model that I was trained in was created by this guy named Dr. Patrick Carnes. He started if I have my data correct, he started the first residential treatment facility for sex addiction in the US. It's called the Meadows, and it's out in Arizona. Carnes did this study where he surveyed a lot of recovering sex addicts over a period of 5 years, really trying to understand what is the makeup of someone who develops a sex addiction. And why I like this particular research is that he was working with folks who were already in recovery. And my experience has been with working with people who have addictions is that as we progress in our own recovery, our ability to honestly report what was going on with our behavior improves, right? We tend to get a little more honest and clear the farther into sobriety or the farther into recovery we get. So I think the data that he was able to collect was pretty meaningful from that perspective. And I have a brief excerpt of an interview that he did where he talks about some of the makeup of sex addiction. So I'm going to pull that up now.
People out there listening that this was so.
Just a second here.
I'm on an airplane. I have a lot of airplane stories.
This is
but there are a lot of people out there listening that this was already.
Is that
underway before they were born. Before they were born.
How's that?
Well, several ways. It's very connected to being in fear. So if you're a second or third generation Holocaust survivor and you hear the stories, you manifest the same kind of PTSD. Or if you're an African American woman in this culture, they have a lot of what we call sexual anorexia, where shutting down being sexual, because they hear the stories of slavery that are unresolved and it's passed from one generation to another. So you hear those stories, or you have, like in my family, my father was very violent, and they would tell jokes about it, and yet I would see him as violent, and I'd see everybody laughing at it, and it would seem so incongruent to me because it scared me to death, and then everybody, Dad lost his hat again because he's in another fight in a bar. So what we know is that the previous generation brings in history, they bring in some DNA, like most addicts have some DNA of nomadic tribes. We know that the dopamine strands are shorter for people who are alcoholic, eating disordered, attention deficit disorder, Tourette's, that they already have a dopamine problem. I mean, we know that stuff. This is before they're really even out of the gate. The next thing that happens, by the age of 2, there's a thing that happens between a parent and a kid where the kid has what is called the gaze of the parent. And what it means, I'm not just changing diapers, feeding, what have you, but where the parent just spends time looking at the child. Very important. They call it attachment. Only 8% of sex addicts get into what we call secure attachment. Basically, they have problems in how they connect with people. Another way to define addiction is a failure to bond.
A failure to bond. That's interesting.
And that affects the brain fundamentally. And then, if there's fear in the family as they're growing up and they're abused, the worst at age 10 for girls and 12 for boys. If it happens at those ages, how the brain actually is structured changes. And all these neurochemicals that excite the brain and make you feel more alive, stress chemicals, we are convinced that stress, first of all, there's a little piece of the brain on the bottom, term for it is corpus callosum. But what it does is it puts in the front part of the brain a chemical called oxytocin that helps you make decisions. That is smaller in kids who are very afraid growing up. Mm-hmm. So they can't inhibit their ability to stop themselves is affected. And then if they're exposed between the ages of 12 and 16, if you get drunk, your chances, say at 13 or 14, chances of being an adult alcoholic, very high. If you smoke, very high. If you gamble, very high. Now think internet.
Yeah.
So it's a big problem.
So part of the reason I share that video is I like that Carnes brings in the impact of epigenetics or the transgenerational sharing of trauma from one generation to the next. And he also talks a little bit about genetic predisposition with addiction. I think that particular piece, about 8% of sex addicts having a secure attachment style, has been very accurate in my clinical experience of working with folks. And I think is a good way to start to conceptualize sex addiction. So as a result of the study that Carnes did over a period of 5 years with sex addicts, he came up with this imagery about the making of a sex addict. And I'll touch a couple pieces of these in particular. I'm going to focus here on this family system. So what he found was that 87% of sex addicts had another addict in the family, mom, dad, brother, sister. 77% came from a rigid family system, rigid implying that the boundaries or the rules or the belief system governing the system was extremely rigid and flexible, probably didn't change a lot as the person aged. And that 68% came from both a rigid and a disengaged family system. So that it's generalized terms, but what he was getting at is that there's a set of beliefs or doctrines or dogma in the system that's very rigid and unchanging, inflexible, which means that the roles in the system are probably going to be pretty rigid and inflexible. And it's also disengaged. So there's not a lot of warmth and connection and attunement happening in the family as well. So chances are, if I'm a child growing up in this system, there's a harsh set of rules that governs my behavior, aka there's probably a lot of shame going around or shame being used as a weapon in the system, and there's not a lot of connection. Those two elements, lots of rigidity and rules and structure that's probably going to lead to some feelings of shame and not a lot of connection, is sort of the soil that sex addiction grows out of. In this green category, he talks about addiction interaction. What he's looking at there is the overlap between sex addiction and other addiction patterns. There's a 61% cross tolerance, which means that 61% of sex addicts also meet criteria for another addiction. That's also been that's been true in my practice as well. It's the norm that people have multiple forms of addiction as opposed to just one. At the moment, I would say the two that almost always run together are going to be sex addiction and screen and internet addiction. Because of the revolution of technology, internet pornography, and smartphones and smart technology, and the ways that dating apps have evolved, it's very difficult in 2025 for someone to have a sex addiction and not have a screen addiction parallel to it. So it's definitely something we want to be looking at. All right. So I've talked about this a little bit, but the kind of three-pronged way to think about sex addiction is that it's a brain disorder. It's similar to other addictions in that once the addiction takes place, structurally changes the brain in a way that some of those connections and some of those neural pathways don't change even with long periods of abstinence and therapy. The other two pieces being that there's an intimacy disorder, which is kind of an adult way to talk about attachment failure, is that the ruptures in attachment that weren't ever quite healed or resolved as a child follow me as an adult, and I take those into my adult relationships. And that there's affect dysregulation, meaning that I have a poor ability to manage my internal state without the use of sexual acting out of some kind to regulate. Just referencing some research here, Nora Volkow was someone who was involved with NIDA for a long time, and she has a study that was done in 2002 where they were looking at some brain imaging, and what they found is that our brains cannot differentiate between sexual arousal and cocaine, which just gives a little bit of insight into what's happening in the brain when we experience really intense sexual euphoria. And what we've learned about substance use disorder and problem gambling is that it has a major influence on our brain's reward system, how we learn, how we experience motivation, and those really important emotional experiences that we've had sexually get heavily embedded into this addictive system. And it really mirrors other addictions. So the takeaway here is that when it comes to this piece, sex addiction is just as much about structural changes in the brain as other addictions are. It's not a moral failure. There was a great study that was done in 2023. And so what they did is they took these criteria for compulsive sexual behavior disorder. And what I like about this particular study, and I would encourage y'all to check it out, is that they did a good job of looking at this pattern of behavior across a variety of cultures and in lots of different countries. A major bias of a lot of research, specifically in the social sciences space, is that it tends to be US centric or Western centric, mostly with white males as the subjects. This is not the case in this study. So they did a good job with it. And what they found is that some of those same regions of the brain that we know are impacted by addiction and substance use disorder and gambling disorder are specifically are congruent, rather, with what's showing up in compulsive sexual behavior disorder. These are some SPECT scans that was done by the National Center on Sexual Exploitation, and what they were trying to look at was some of the damaging effects on the prefrontal cortex, or our thinking brain, of compulsive pornography use. And so you can see this imaging here on the right of these kind of holes and lesions in the brain as compared to this healthy one. And what I think is interesting is who conducted the study. That's the National Center on Sexual Exploitation. So what they're really looking at is they're looking at assault. They're looking at how people are sexually solicited online by unwanted others, which is a major issue for a lot of young people who spend a lot of time on the internet today, is getting solicited by adults or people they think might be peers but are hiding behind the anonymity of a screen name of some kind. So I think it's interesting that they had the insight to know that someone getting exposed to a lot of pornography has a lot of potential to affect sexual exploitation. One way that this manifests in our world today is in this cultural issue we have around, different terms for it. One would be like digital exhibitionism, which means I send erotic photos of myself to someone else that does not want them, did not ask for them, or I kind of harass them to send me erotic or nude photos of themselves, which is a pretty common problem that I see show up for teens who develop problems with porn. And that might be one of the precursors to them coming into treatment, is they've had some kind of a consequence related to sexting. That their school or their parents or the parents of the other individual becomes privy to, and then they get into therapy to explore it. How that can happen, one way that it can happen is that a young person gets exposed to pornography early, and maybe they have lots of access. There's not a lot of limits being set with their screen use or much monitoring, or maybe mom and dad aren't talking to them about porn or sex or masturbation. And so they get exposed to a lot of pornography. And over time, what starts to happen is they develop tolerance, right? They have to watch more porn or more extreme porn, or watch content in situations that are a little more risky where they could get caught. And they develop tolerance. And so developing tolerance with a sex addiction, specifically with porn, is a little bit different in that what can happen over time is the level of stimulation that my body needs to maintain physical arousal and eventually achieve orgasm becomes dependent on the level of stimulation I get from the content. And if I watch enough pornography over a longer period of time, what's going to happen is that the level of stimulation I require to maintain physical arousal is going to exceed what I can experience with another person. And that comes with some implications. One is it creates something that's called porn-induced erectile dysfunction, which is essentially means I need to be able to watch a certain amount of porn to maintain physical arousal in my body. And if I don't have enough of that stimulation, it's not going to happen. And so how that can translate to some consequences with sexting, or how it might translate to sexual exploitation, is if I'm a young person, I've developed tolerance with watching a lot of pornography, and maybe over time, to amp up some of the stimulation, I start to have sexual conversations online or with my peers that are very, graphic and erotic in nature, and maybe happening with lots of people. And so my tolerance builds. And then let's say I get into a dating scenario where maybe there's someone in my school that I'm interested in, and we start to, talk back and forth, and the conversation becomes sexual or flirtatious in some way. And once we enter into that space, again, remembering that I've built up all this tolerance, I am probably going to experience a lot of urgency and desperation to move this conversation to a very heightened sexual space because that's what I'm accustomed to. And the other person might not be meeting me there. I mean, they might be just in the very beginning of noticing attraction and sharing flirtation and that kind of thing. And all of a sudden now I'm pressuring them for photos or sending them photos of me because I'm trying to advance this conversation to a place that's more sexual based on my tolerance building. And I'm probably going to get upset because this person is not responding to me in the way that pornography does. And in that place of urgency, that's where a lot of this kind of sexual harassment or sending or wanting to be sent unwanted photos can take place. I mentioned earlier this concept called affect dysregulation. And so this term and this model of looking at addiction is based out of affect regulation theory and Alan Shore's work. There's a great book by a woman named Alex Katahakis called Sex Addiction as Affect Dysregulation. I have a slide with it on later in the presentation. I definitely want to recommend her work. And the takeaway is this, is that I'm not securely attached. I don't have good skills of how to regulate distress in my body. And I discover that sex and porn and masturbation and fantasy is a way to move myself up and down the ladder of regulation. So when I get too anxious, I get too angry, I can act out sexually, I can masturbate, and I can bring myself back down. Or when I get depressed and low and lacking in energy in my body, I can use what might be the conquest of sex with a new person or the fantasy of love and getting lost in the thralls of that as a way to elevate myself out of a low state of stimulation or a lower emotional experience. I want to pause here for just a second and see, I'm conscious I'm moving quickly through this material. Any questions so far?
I actually have two questions. The first one is the pictures you showed with the scans of the brain, and the brain, when consuming porn. Do those brain changes like stay consistent over time, or is that like just when they're consuming porn? Or, like, is there any, and you might not know, but like kind of like long lasting effects on our brain? Or is that just a snapshot of when the stimulus is occurring?
Great question. So I'll start with the first one. So that's the impact of prolonged addictive pornography use. The good news is that those is the brain can heal, right? Neuroplasticity is real. The brain continues to grow new cells and make new connections. There's some markers of time that we know is typically when we're going to see more significant changes in the brain. It tends to be around 9 months, 18 months, and 5 years of abstinence and being engaged in recovery is when we're going to start to see the brain heal in a more significant way. The part that does not change is the wanting. Mm-hmm. So I'll be specific what I mean. So there's kind of two arms in our brain connected to any kind of compulsive behavior, and that's how much we want it and how much we like it. And this how much we like it piece is the one that gets way destabilized, where initially it feels really good, and then we got to continue to use it more and more compulsively, and we actually like it less, right? That's part of the problem with addicts is at the end, they actually don't really get that much euphoria out of the behavior. It's part of the reason they have to do it so much. It's the wanting it that doesn't change. Okay. Which means that their ability to use it in balance is going to be really difficult.
Got it. That was really helpful. Thank you. And then my next question, which you did touch on this, but I'm thinking, more about some of the kids we serve. We work in residential treatment for adolescents, so ages 7 to 14, specifically with the males. Do you see, this like increased need to kind of up the ante on what they're doing in order to get pleasure ever turn into like perpetrating behaviors? Because we see a lot of, pornography use, and, most of the children we work with, have experienced some level of trauma, disrupt attachment. And so a lot of them have a history of sexually acting out on others unwantedly, whether that's like a sibling or a neighbor. So, is that kind of like that last step, and upping the ante is like turning into sexual aggression?
There's yes and no.
Okay.
There is overlap, and there's a visual I have to attempt to describe this very issue later in the presentation. But what I will say is that there is an overlap, and that sometimes, especially if a young person has experienced, let's say they've experienced all of their sexual education both through pornography and maybe a traumatic sexual experience with another person.
Right.
Those are the sources of information they have for what is sexuality. Most internet pornography that's free is marketed towards straight men. And there's a couple underlying sub themes that have some very heavy influence on sexual attitudes. Several that are common. One is the inclusion of violence.
Mm-hmm.
And another is this idea that sexual gratification is detached from connection with another.
Mm-hmm.
And so those themes emerge sometimes in the way of what we, sexual violence or taking a sexual experience from someone else without their consent, because I've been so heavily inundated with this imagery connected to those kinds of, ways of relating to others. That's not to say that everyone who develops a sex addiction acts out in a more sex offending type way, but there can be a significant amount of overlap.
Right.
So I think young males especially, the ways that their sexual attitudes are formed and influenced by pornography, especially if there's not another adult that's kind of giving them context for those experiences or like setting limits so they're not watching porn, it can have a really significant impact.
Got it. Thank you. Yeah.
Thank you for your question.
Yeah.
All right. Like I said, as more questions come up, let me know, and I'll do my best to address those. I'm going to go for about another 5 minutes or so here, and then we'll take our first break. So the way the human nervous system has evolved is we have evolved to do what's called co-regulation. Co-regulation means that we're not wired to become upset or become anxious, turn inwards, and resolve that experience for ourselves. What we're wired to do is to become upset, to experience distress, and to look for ideally a larger, more stable nervous system that we can borrow stability from long enough to smooth that experience out. So an example being that a child has some experience of shame or anxiety at school. Maybe they're not fitting in as well as they would like to, or they didn't do as well on a project, and they come home and they're upset and distressed about that. And a parent, a caregiver brings them in and pulls them close to their body and maybe squeezes them tight and holds them for a prolonged period and talks in soothing tones. And over time, the longer we stay in that space together and I allow the child to have the emotional experience they're having, it's probably going to start to soothe and adjust. That would be one simple example of co-regulation. For a lot of sex addicts, that's probably not a really common experience that they had growing up, or at least wasn't consistent. And so this idea of like a secure base, simple definition for a secure base attachment-wise is that I know in my mind that some people back here have my back, and I have a safe place to go to unpack the pain that life deals me. And I can trust that they're going to be there when I really need them most. And that basis of trust and security allows me to go out into the world and to explore and to take healthy risks and to try on connecting with other people, knowing that when those experiences might not go so great or I make mistakes, I have the secure base to come back to. So the folks that didn't happen for are going to be far more likely to develop addictions of all kinds, and in this case, sex addiction. Another outcome of secure attachment is it helps me to develop a healthy, what we would call an internal locus of control. One way of referencing our locus of control is that I have a clear idea what I am personally responsible for and what I can do on my own, like how I can actually be self-sufficient. And I also have a clear idea of what I need help for. And as a result of that, I'm probably not going to experience a lot of difficulty asking for help when I need it. Now, I don't know about y'all, but I haven't run into a lot of addicts that, sex addiction or otherwise, that are masters of asking for help. Typically, those of us who have addictions are going to try to solve things on our own. We're going to try personal convictions. We're going to try lots of different methods. And In a recovery sense, they might even try reading a lot of books or watching videos and any and all methods to arrest the behavior without asking for help or getting support from others. And I don't think it's any mistake that if we look at 12-step fellowships and what the 12 steps involve, the first step is accepting powerlessness over the unmanageability of my life and this addiction that I have, which implies that I have to have the help of others, right? I don't think there's any mistake to that. So I'll go through this particular slide and then we'll take a break. So this is just a list of examples of some reports I've heard from young people and in clients reviewing their history about how sex, pornography, and the use of the internet becomes a solution to regulate when I don't have a better option. So I'll read through these. Mom and dad are arguing for several hours. No one comes to talk to me about how I'm feeling. I get so anxious I become nauseous, and I watch 3 hours of pornography and message people on Instagram to get nudes, and then I fall asleep after I masturbate. So what we can see is that there's a rupture in attachment. Mom and dad are arguing. That scares me. They don't connect and make any kind of repair with me around that. So I'm left with all this churned up anxious energy in my body, and eventually I have to get to sleep. So I become creative to find ways to move my body into a state of numbness, both with pornography and switching through lots of different videos, messaging with lots of different people. If I'm task switching, right, and I'm moving on my phone from watching porn to messaging with people, and then eventually I start to masturbate, those are lots of ways that I can stay out of my body and be disconnected from the painful emotional experience that I'm having. And if that happens with any kind of a repetition, what's probably going to happen is this pattern is going to get baked into my sleep cycle. That's really common with a lot of pornography addicts or people who struggle with porn. That's a good question to ask is, do you watch a lot of pornography at night, or is it the last thing you do before you fall asleep? And they'll probably be convinced that that's the only way they can fall asleep because it can become mood regulatory that way. Another example, I had a bad day at school. When I tried to talk to mom and dad about it, they seemed really busy. I know they both work a lot. I tried doing homework, but was so distracted by how sad I was, I couldn't stop scrolling Instagram and lost track of time. My homework got turned in late, and my parents were upset with me. When dad gets angry, it makes me nervous. It's hard to tell him how anxious I get when he's upset, so I try to stay calm about it. At night, I get restless, and that's usually when I'll scroll social media and message people on apps until I can calm down. Sometimes older people message me on Discord, and I'm excited by the attention. So this last one was with a client who came to me under the auspices of having a pornography addiction, which he did. But his porn addiction was really born out of an abuse experience he had online where a group of adult men essentially exploited him through Discord. Discord is a kind of message board forum app, if you're not familiar with it, pretty popular amongst young people. And in this group, essentially what happened is these older men coerced him into watching porn for the first time and then repeating some of the behaviors he saw in porn in videos that he made of himself and then sent to these people. And as a result of that, he developed a porn addiction. He had really early exposure. But cases like that are becoming more and more common. I'm noticing where young people can have a lot of their early experiences of sex highly influenced by strangers online because that's where they're pursuing these conversations, especially if no other adult in their life is initiating one. So I'm going to pause here for now, and we will take our first break. So we'll meet back here in 10 minutes. So we'll start back up at 10:12, and I will see you all in a bit. We've talked a little bit so far today about how sex and pornography addiction can be a creative way to regulate my affect or regulate distress or anxiety in my body. This is just another lens and way to explore that. So this is looking more at how I hold on to my sense of self and how I feel like a person in the world who has a sense of power or mastery over my environment. So a quick example of how sex and pornography can come into this. let's say I'm a young person and I'm in school and I experience some kind of shame, whether it's the sense that I'm not really fitting in or belonging, or maybe I perform poorly in a way that others might humiliate or harass me. And I experience a dent in my ego, a dent in my sense of self, who I am. And as a way to move away from that sense of shame, I divert my attention to a place where I have more control and a little more mastery. And if I've been watching a lot of pornography, or I'm engaging with folks online about sex, that might be a place where it feels like I have some control over my environment. I know that this place is a little more predictable, and I can get affirmed from others based on their desire or interest in me sexually. And as I engage in that pattern, it kind of helps me shake off some of these feelings of shame. And my sense of who I am in the world gets put back together a little bit. I can hold on to something that makes me feel worthwhile. That pattern gets emphasized to a greater degree because it's also connected to a lot of dopamine if I'm watching pornography or engage in lots of sexual conversations with others. Where this becomes problematic is if that pattern becomes rigid, or that's my go-to, it's my primary way of dealing with pain in the world, and that perpetuates over time. Chances are what's eventually going to happen is my sense of who I am, my identity as a person, is going to become directly connected to the sexual acting out behavior. We talked a little bit earlier about this relationship between sex addiction and attachment. And some studies suggest that only about 8% of people who meet clinical criteria for a sex addiction have a secure attachment style. And so this was a series of studies that were done looking at attachment styles in different groups. And here in these last three columns, we can see some of the breakdowns of kind of these classic four categories of attachment style that you'll find in most of the research. And as you look across there in our control group, the regular college sample, about 57% of people, the majority, have a secure attachment style. And moving on down the line, and what we'll see here is that for the majority of sex addicts, both male and female, we're far less likely to see secure attachment styles. We're much more likely to see preoccupied, dismissive, or fearful avoidant. It's been my experience that the majority of people who really meet diagnostic criteria for a sex addiction are going to hover closer to fearful avoidant in the way that they attach and relate to others, which briefly is a combination of both experiencing a lot of anxiety and relationship insecurity, meaning if I'm in a relationship with someone, I'm going to be pretty heavily concerned about their level of interest in me, and that's going to become greater when there's distance. So the more distance, metaphorically or literally, the more anxious I'm going to become about the security of my place in the relationship. And I'm also going to be avoidant of closeness at the same time, meaning I will avoid conversations that involve conflict. I will avoid experiences of vulnerability where we share intimate things about one another that lead to a greater understanding and a sense of being known. I'm probably going to avoid those experiences greatly. And so how I'm going to relate to others is this kind of come here, go away, push, pull that typically leads to a lot of relationship instability. It's tough to maintain long-term relationships with that pattern of relating. This is just a quick way to differentiate between what we might call kind of classic or conquest-based sex addiction and more contemporary sex addiction. And I think the easiest way to think about this is this classic group is more likely to be folks who did not grow up on the internet, and this contemporary group is more likely to be folks that have. And the classic group, what we're typically going to see with sex addiction is we're going to see a significant history of abuse. There's probably going to be some early onset of exposure to porn or sex or sexual an unwanted sexual experience even. There's probably going to be multiple addictions on board. You're more likely to see mood disorders. And these patterns are likely to have evolved over a longer period of time, maybe 5 or 10 or 20 years. Whereas with more contemporary sex addiction, you're more likely to see rapid onset where someone maybe has only been watching or using pornography for 6 months, but comes into your office already heavily addicted, maybe experiencing some of those symptoms that we talked about earlier, like porn-induced erectile dysfunction, which is very common in young people right now, where they're ability to maintain physical arousal in their bodies has become dependent on pornography, and they struggle to have sex with others that doesn't involve porn. It's also more likely in this group you might be working with people who have never been sexual with another person and may not actually be interested. That's something I've noticed in younger generations, or with Gen Z in particular, is their level of desire to be sexual with another person seems to be significantly lower than previous generations. And I think that's fairly easily explained by the focus on non-relational sex that can happen both through pornography and through what we would call asynchronous communication. Asynchronous communication is texting or messaging where I communicate something, but the other person might not respond immediately, and I don't have the ability to look and perceive the impact that my words or my communication had on their face or their body. Then we can sync those experiences together. When I have lots of asynchronous communication, it's a less relational experience. And it's a little easier typically for me to maybe be more selfish or aggressive in taking a sexual experience that I want that lands on the other person, potentially like a lack of empathy. So just to provide a little bit of context there. A simple way to think about pornography is that it's the crack cocaine of sex addiction. The reason for conceptualizing it that way is that it has the ability to rapidly escalate someone from what might be more normative recreational use of pornography to something that's highly addictive. There's a bunch of different factors and why. One is these 3 A's that I have listed here: access, affordability, and anonymity. Those 3 things are predictors of how addictive a particular behavior or stimulus can be. And in most cases, the higher, what's the word I want to use there? The more access I have to these 3 things, the more likely something is to become addictive. Access is just about, can I get it? Affordability is how much it costs. And anonymity, of course, is that I don't actually have to show up anywhere and experience the vulnerability of my face and name being connected to this behavior. And so if those 3 things are on board, something's much more likely to become addictive. And for all of us who carry any kind of a smartphone or smart technology, at any moment, we're seconds away from being able to watch pornography. The vast majority of internet porn is free. And I don't have to identify, in most cases, who I am. Some states, are taking some action on that, Kentucky being one of them, where, there's more filtering around having to have an age connected to being able to watch porn or put in an ID and that kind of thing. I do think those efforts are worthwhile, and it's important that states and or the federal government attempt to protect youth from early exposure to pornography. For all the reasons that we've already talked about. I'm not confident that this particular method of doing it is having the intended effect, just because my experience with clients has been, once they hit some of those walls, they just search into darker corners of the internet to find the same content. Because some of the less established platforms like Pornhub aren't abiding by the same rules of legislation. This other piece is this last one here, this fusion of dating apps, culture, and sexual arousal. It's that apps like Tinder and Grindr have found a way to really mimic the experience of pornography, or even mimic the experience of something like TikTok in their platform. And that once I have all these folks suggested to me that I could be potential matches for, I'm scrolling rapidly. In most people's experiences, they scroll rapidly through all of these pictures and all this content, becoming more sexually aroused as they peruse. And the escalation is going to happen to a greater degree once they start matching with people. But the endless novelty of that, if I just go to one person to the next very rapidly, mirrors the experience of internet porn. And that what really cranks up the level of dopamine I get from that experience is the access to the next video. It's not the video I'm currently watching. It's my ability to achieve more novelty endlessly by going to another video within, a click of a button and within seconds. And so the speed of that reinforcement is what can escalate the addiction so quickly. I covered this briefly, But this is just a kind of a graphic way or an image to describe how a pornography addiction can escalate quickly. And the simplest way to think about it is that internet pornography is a super stimulus or an abnormal stimulus, which means as a species, we have not had a lot of time to acclimate and use this particular behavior imbalance. None of our grandparents were able to have access to the internet pornography that we do today. So no subsequent generation has had time to work out how to use this imbalance and then pass those genes on. So anytime there's a new stimulus like that, a good example is methamphetamine. Likely none of our grandparents were using or great-grandparents were using methamphetamine that we have access to today, which contributes to how addictive it is. Porn is the same way. Over time, the more we watch, we're going to develop tolerance. And there's only a couple ways to manage tolerance once it comes on board. One is I can increase the frequency. I can watch more pornography. Another is I can increase the risk associated with the behavior, which means I might watch it in places where I could get caught. Or if I'm in a relationship, I start to risk what would happen if I were to get caught and hurt the other person. What we know through the neuroscience research is that anytime there's an inclusion of risk, it increases dopamine production. And the third way is novelty, something new. And so with pornography, what's common is as my tolerance progresses, I'm going to go into different areas of sexual experience that might be more taboo or might be more violent or might even stretch beyond my sexual orientation. And again, that's about the pursuit of novelty to increase tolerance. And over time, this might lead in to some content that could come with some legal consequences, like child pornography or looking at pornography that's younger and younger, or looking for people that are younger and younger. It might include something like bestiality. With all addictions, the earlier we get exposed, the more likely we are to develop a compulsive problem later on. Some other things to mention with porn is that if someone is exposed to a lot of porn, let's say before the age of 16, which roughly is about the time that most folks are completing puberty, that when I'm exposed to that kind of imagery during this very important phase of sexual development, I'm much more likely to develop things like fetishes. And the truth about fetishes is once I really have one, it's not going to go away. And so the work then becomes acceptance, but oftentimes fetishes can be problematic for folks in that it might narrow the other people that I can be sexual with that might meet my level of interest. And so for a lot of reasons, it can be important really to minimize the level of exposure that young people get prior to completing puberty. While I'm on this topic, I just want to put a little bit of a disclaimer. I am not anti-pornography or think that in every context porn is harmful, because it isn't. In some cases, I might even prescribe some more ethical pornography to a couple that might be more sexually anorexic or something like that. But for the majority, porn is typically very harmful for young people, especially if their access is unlimited. This is kind of getting a little bit to the question that you had earlier, Brianna, about kind of what's the overlap between sex addiction and sex offending, or how do they relate to one another? And just to provide a little bit of definition, the terms mean quantitatively and qualitatively very different things. Sex addiction is part of a diagnostic framework that's similar to substance use disorder or problem gambling. And it's really about a dopamine downregulation of behavior, meaning that over time, there's structural changes that occur in my brain as a result of the addictive pattern. And we know it is also involved in a pattern of an intimacy disorder. Sexual offending, on the other hand, is in and of itself, it's only a legal term. So that term, sexual offender, when it's labeled on a person, really tells you very little about what their behavior is. All it tells you is that they've been guilty of a crime. And there's a whole host of different behaviors that can make up sexual offending. And sometimes there is overlap. A quick thing I'll mention is that some sex addicts do offend, but not all. Some sex offenders have sex addictions, but not all sex offenders do. This image is an attempt, and I'm hoping that some of those kind of overlaps with the bubbles there are coming through on your alls, and it's an attempt to conceptualize what's the overlap and what isn't, and how those spaces intersect. This is based on the work of a woman named Dr. Monica Meyer, who for a while was the clinical director of a place called the Meadows, which is a residential treatment facility for sex addiction. So I'm going to give you all just a second to take that image in, and then I'll talk about it. This topic, differentiating sex addiction from sex offending, is its own, multi-hour course. A couple things that I'll point out, though, for today is that through the escalation of a sex addiction, so sex addiction, like all other addictions, typically is a progressive pattern that gets worse, not better. And as that problem progresses, my behaviors, if I'm acting out with other people, again, with those three arms of increasing dopamine production, novelty, risk, and frequency, might start to bend towards an offending behavior. So what that might look like is maybe it starts with pornography and masturbation. After that, I develop tolerance. I start messaging with other people online. And then after that, I start to meet up with people and have anonymous sexual encounters. And then maybe I start to cruise in my car, looking for people who might be potential sexual partners, some of which could be sex workers. Others might just be people walking on the street. And over time, as my filter of the world becomes more sexualized, I might start to exhibit sexual behaviors that are more offending based, where I might expose myself to someone else that's unwanted in a literal space or in a digital space, like sending pictures, or I might engage more in some like frauderism, where I get onto a bus or the subway and I start to touch people in a sexual way that's unwanted or doesn't involve consent. So those can be examples of how a sex addiction at its onset progresses into an offending behavior. And what you'll see here in the middle where there's overlap is some of those things I mentioned, like frauderism, voyeurism. Maybe, a common example might be if I'm in a relationship and I have a porn addiction, I got to start to get more creative about how to find privacy and a way to maintain the secret from my spouse. So maybe I start to leave the house so I can watch porn, and I might do that in my car, or I might say that I'm walking the dog, but I'm actually looking at my phone and scrolling porn. And then as I'm doing that, I might start to look around the neighborhood and notice that some houses have their curtains open and I can see into their house. And as a result of that highly sexualized erotic space I'm already in, I might start to engage in voyeurism as a result of that pattern escalating. What you'll also see in here is child pornography, and I'm going to talk a little bit about that in some more detail. So this is I just want to acknowledge, this is a highly charged space, because what we start to get into are crimes against children, or people who might meet criteria for pedophilic disorder or might engage in child molestation. And so I just want to acknowledge that even in a place of mental health treatment where ideally all of us are a little more cognizant and aware of our own biases, this is one area in particular that can be tough to talk about. So as I go through this content and as we get further in the presentation, if you need to take a break, do what you need to do to take care of yourself. But a little bit of data and research that I want to share with you all about child pornography and the people who consume child pornography is that sometimes there is this assumption that all people who consume child pornography or watching videos of children that involve some kind of a sexual or erotic content are sexually aroused by children, want to have sex with children, or are at risk of perpetrating an offense towards a child. And the reality is that isn't true. There is a causal relationship between the consumption of child pornography and committing a sexual offense is kind of the biggest myth that exists around child pornography, or people who consume child pornography. Another is that anybody who looks at that kind of content must be a pedophile or meet criteria for a pedophilic disorder. And that's also not true. So this is a synthesis of a lot of the research that's been done about these different groups of people. And I'll be clear about why I'm bringing this up, is that a lot of folks that I've worked with who their behavior is more fixated with pornography, or maybe they've had a porn addiction for longer than 5 years, it's not uncommon that at some point they may have consumed some material that could be considered child pornography. In many cases, these are not folks who meet criteria for pedophilic disorder or have any history of contact offenses with children, or per any assessment that evaluates sexual orientation and interest or paraphilic disorder, would they show up whatsoever. When it comes to pedophilia, some of these people really start to pursue content of people who look younger or look more novel simply as a result of their pornography addiction. All that said, that doesn't make their behavior less problematic, coming with consequences, perpetuating an industry that engages in human trafficking and sex trafficking. All of that is still true. But it's important to know that just because someone consumes child pornography doesn't necessarily mean that they're at risk to harm a child or engage in a contact offense. Some of what showed up in this research that I looked through and the work that's been done is that people who do commit contact offenses behave in a categorically different way on the internet than people who don't. So someone who does meet more criteria potentially for pedophilia, or who has committed contact offenses, what they're more likely to do is they're more likely to download and keep a cache or a storage of a lot of that content, and they're likely to share it with other people on the internet or sell it, or they're more likely to engage people on the internet who might be younger people and engage more in a sexually exploitive situation that involves coercion. It's very rare that consuming child pornography is going to be the only behavior that they engage in. What the research suggests is that most people who do commit contact offenses do so before consuming child pornography. And if we look into it a little further, what researchers have noticed is that sometimes people who commit contact offenses use child pornography as a way to stay away from committing harms against other people, as opposed to the other way around. So all that to say is just to bring some of this up in your awareness as you start to explore and look at working with sex addiction or porn addiction with people. It's important to have some of these potential ethical dilemmas in mind, and to know that it's important to be able to educate your clients. Hey, if you report to me that you've consumed child pornography in the state of Kentucky, that is a sex offense and has to be reported. So it's important you can give people context about how to talk about some of these issues, and so that you can protect yourself from a liability perspective. Something else to mention here quickly, especially for those of you who are working with adolescents. In the state of Kentucky, the way that the laws are written when it comes to the collection and distribution of child pornogaphy, there is no distinction between two consenting minors sending and receiving erotic photos from each other, and a 50-year-old person doing that with a 10-year-old. There's no distinction in the laws. So two 17-year-olds who might be in a relationship who send each other nude photos are guilty of the collection and distribution of child pornography in the state of Kentucky. And some of those cases have been pursued, and some of those youth have been placed on the sex offender registry as a result of that. So it's super important to educate your clients about the bounds of confidentiality in this space. I want to pause here for just a second and see if there's any questions before I continue.
Just a quick question based on what you just said. So if we're working with a teenage client and they start talking about how they have, sent a nude image or have received a nude image, would we need to report that in the same way that we would if they were talking about, if this was an adult?
Technically, yes. And as you get into the reporting of that, you'll there's some specific details that are necessary to make it a
Right.
report that's worthwhile at all.
Right.
So I'll tell you how I try and educate my clients about this so that they can just make an informed decision.
Mm-hmm.
So in my consent to treat, so when I'm starting therapy with someone, when we talk about the bounds of confidentiality around, if you have any plans to harm yourself and means to do so, I have to make a report and try and keep you safe. In that conversation, I mention this. And I go into greater detail about it with anyone who comes to see me under the auspices of a sex or porn addiction, so that they know, hey, if you tell me that you have consumed pornography, internet, video pornography that involves a child, a minor person, that's a reportable offense, and I have to contact the authorities about that. Now, all that being said, if someone makes an admission like that, and the victim is not identifiable, there's not much of a report to follow up on.
Right.
So it's just knowing that. But so typically I will give clients that information, and then so they can come up with some ways to talk to me about that behavior. And I'll give a little bit of a distinction here. So it's my bias that it is not going to benefit a 15-year-old child who is exploring their sexuality with another 15-year-old and having erotic conversations. It's not going to benefit them to end up on the sex offender registry as a result of that.
No.
And our laws have not kept pace with the advances in technology, and I think that would cause harm. So I lean towards the direction of trying to create ways for them to talk about it that aren't incriminating. And the other end of that is if someone is reporting to you that they are engaging in some kind of a contact offense with a non-consenting person, and you are not a sex offender treatment provider or an SOTP that's trained in the state of Kentucky with those protocols and the ability to do a risk assessment, that they should be referred out.
Yeah. Okay.
So that's kind of the context I give to my clients, and there have been people who, if they have engaged in contact offenses, I refer them to a sex offender treatment provider. That doesn't mean they might not still have an addiction, and I can work with them on that front, but I won't be the only person working with them.
Got it. Okay. Thank you.
Sure. Thank you for the question.
Yeah.
Any other questions right now? All right. So for the rest of the presentation, I'll be talking about treatment. And I'm going to do my best to give some kind of broad ways of thinking about treatment and things to have in your mind. And other things will be more practical approaches I'm hoping you all can implement soon in your practice. So I'd like to start here, which is if I'm stepping into this space of working with sex or pornography addiction, my experience has been one of the primary barriers to successful outcomes with clients is my countertransference, my internal and external reactions to clients when it comes to talking about sex. And I don't know about y'all, but when I was in grad school and experiencing my initial training, how to talk to folks and work with issues of sexuality was not something that came up, and I did not get specific training in that. So I just want to acknowledge that oftentimes, especially if we're earlier in our career, there's not a lot of robust instruction we get of like, how do you work with people with sex? How do you talk to them about sex? How do you manage my own stuff that shows up around talking about sex, sexual beliefs, sexual attitudes, and that kind of thing? So I just want to acknowledge that all of us have our own set of biases based on how we were raised and our experiences that we bring in to the therapeutic space. And it absolutely has impact with our clients, and our ability to be honest about that, to notice it and be able to work with it in the moment greatly improves our ability, my experience, our ability to be effective in working with people. So what I have here are just a few prompts that can help on the initial end to explore like what might be some of my biases and what might show up for me if I really lean in to working with some of these issues with sex and pornography addiction. And so what I'm going to ask each of you to do is we'll take 5 minutes here. And I'm going to ask you just to look at some of these questions that I put up here on the screen And if you have some paper or a notebook next to you, you might just make some notes and take a moment to answer and reflect on some of these questions. Again, just as an initial way of starting to explore some of our biases with talking about sex. And in 5 minutes, I'll check in. Right. So again, in my hope to normalize as much as possible that in the same way that all of our clients, when they walk into our offices, have their own history and story and complexity of their own beliefs and experiences with sex, so do we. And the shared experience of getting into that vulnerable space is an important one, just to be able to own and acknowledge with each other. So my hope is if you're in practice that you have some trusted others, colleagues that you can talk to about your own experience of countertransference with people. And I do my best to be accountable to that as a practitioner. And I'll share some of my own answers with this. So this first one of where do I notice repulsion or contempt is a way also for me to be mindful of who I might not be a great fit for clinically. Where I can experience some repulsion and contempt is working with people who do commit contact offenses against others or against children, and it's egocentric for them. Egocentric meaning that I engage in that behavior and it feels in integrity, it feels good to me, versus ego dystonic, where I engage in these non-consent experiences, but I feel tremendous amounts of remorse. I notice I can work with that and not experience a lot of internal cringe or contempt in my body. I don't notice that when working with people who it feels egocentric for. So that's why I don't treat those individuals. And when I meet them where they're at and I refer them out. And where I feel most awkward at the moment is in working with some young people who might be more engaged in the furry fandom space. And if you're not familiar with furry fandom, it's the overlap with sexuality is that I might kind of anthropomorphize myself, where I might wear the clothing or a costume that in some way mimics an animal of some kind, and that has a sexual overlap to it. And I might exchange content with people, or I might get together with others and have sex that engage in an anthropomorphized version of themselves. It's awkward for me because I don't have the best understanding of the value in that particular behavior, and I have a judgment that it at times is exploitive for young people online. So I've noticed that can be an uncomfortable space for me to work in, and I do my best to be aware of that and seek supervision and consultation around it. So all that said, anybody willing to share something that came up for them as they explored these questions for themselves?
I think with me, what would be really hard for me is I'm a foster parent and I take in a lot of children that have been abused and stuff. And for me, dealing with someone that is perpetrating on these children would be really hard for me. Because I see the effect that it's had on these kids, the life altering effect, some of these kids have experienced from the abuse. It would be hard for me to be on the other side of that.
Absolutely. Yeah. Thank you for sharing. I appreciate your honesty.
I would agree with that. For the first question, I put sexual offenders, specifically dealing with children, but also those who have like little to no remorse or low motivation to change. If they're mandated for treatment, but the motivation to change is not there, then I feel like that would be really hard for me. Just to find some sort of like non-judgmental path with them, I think would be really difficult. And then I feel awkward, and this is from my own experience working a little bit with, we did end up referring a lot of these clients out, but adolescents who have almost like compulsive masturbation habits and not knowing talking about that can be really awkward, and what's healthy and what's not, and hearing about that. And then also clients who, have some sexual acts with animals is very uncomfortable for me as well. So.
Thank you. I appreciate you sharing. And
Me, oh, I'm sorry.
go right ahead, please.
I can say for me, when I do a lot of couples work, and when I work, it has been men in particular who have a very entitled, kind of egocentric expectation with sex. So it's sort of that classic, like, I watched the kids for 2 hours and then, she wouldn't even have sex with me. That kind of tit for tat transactional. I have to do a little bit of deep breathing and recentering around that. And I think that the people I'm maybe not a good fit for are sort of uber religious people who put those overlays on what's okay and not okay. And I don't know that there's anything that I know how to do to help like find some wiggle room in that perspective. So I'm not a great fit for those clients.
Wonderful. Thank you so much for what you shared. Just respond quickly to it is common. I've noticed not only, again, with men who might fit that more kind of emotionally mature narcissistic profile, but also men who spend a lot of time on the internet watching porn as their main source of education with sex, is that they can kind of have this approach to relationship that really mirrors the transactional nature of sex and places if they're heterosexual, it places their female partner in the box of what they have learned about women and what being a woman is in the space of pornography, which is a very objectified, lacking in nuance, two-dimensional version of a person. Where I approach relationship, maybe as a parent, like, I watched the kids for 2 hours, or I went to work this week, and so I put several kindness coins into you, and now I'm upset that sex isn't coming back out. And that might be my reference for how to be in a relationship. So I would also just acknowledge that what happens for you in response to that can also be helpful information to bring into the room, because chances are, I imagine what's happening in your body might be similar to what happens in the body of their partner in response to that behavior from them. So thank you all so much for sharing, and I'll continue. This is something I've kind of learned along the way, that my experience is that therapists often select the intervention or the approach that resolves our anxiety and not necessarily the anxiety or distress of the client. And so how I see that show up in treating sex and pornography addiction is that if I encounter a situation that's more sex addiction based, and maybe I don't feel as comfortable confronting it from that angle, I might shift it into a model of work that I'm more comfortable with, like working with trauma. That is not at all to say that trauma work isn't super important for people who have sex addictions, because it absolutely is. But if I start there and I miss the opportunity to really acknowledge and address the addiction for what it is, I'll probably do a disservice to the client. So we'll talk a little bit about treatment and hopefully get into some things you all can incorporate in your practice. Super important that we do a full sexual history with our clients in the same way that we might do a full history with their experiences of relationship or caregiving or medical history. And these are just some questions and some areas to explore. And use your skills of building rapport with someone in the early stages of treatment to shape these questions and tailor them to the client. But these are some areas to explore, especially if someone comes in already acknowledging that there's some kind of a sex or porn addiction on board. I want to know about their firsts. Their first and initial experiences of sex can be very telling and very symbolic in how they might draw meaning from some of these experiences that it affects them today. So those would be things like, can you tell me about the first time that you remember having a sexual fantasy about another person? And what did that fantasy entail? Give me a picture. Help me understand what was the draw of that fantasy, or how that was meaningful for you. or talking about their initial exposure to masturbation or when they first discovered masturbation, which is a good entry into, did anybody in your life talk to you about masturbation? What were the ground rules that you were given about what kind, how to masturbate and to what degree would that be out of bounds? Are there any rules around it? That sort of thing. And I want to learn about their initial exposures to pornography. Did they do that on their own? If so, how and why did they have access? If someone else introduced them, it's important to look at how that affected that relationship and relationships after. Some other things to explore are what might have been some of the family attitudes about sex. Questions can be, what sort of conversations about sex did you hear growing up? Did you hear any ever? And if they didn't, which is very, very often the case when I ask people this question, who talked to you about sex? Oftentimes it was no one. And if that's the case, I've found it to be most accurate to conceptualize that as a form of neglect. That it's neglect to not educate and give a child context about a foundational element of their lives like sexuality. Because if that doesn't come from an adult, it's most likely to come from pornography, which is a poor source of sexual education for a young person because it misses tons of nuance around consent, tons of nuance around emotional connection, tons of nuance around safety with sex, physically and emotionally. And if sex isn't talked about, most of us are going to interpret that as because there's something wrong with it. Sex is bad or shameful in some way, and that's why we don't talk about it. Of course, we want to explore any instance of sexual abuse and looking at when someone's first sexual experience was with another person and exploring if that was a experience they chose or one that was forced upon them and looking at how that carried meaning for them about how they understood sex. And if there is a pattern around secrets, we want to look at when did they first start to know that it was important to keep secrets about their sexuality and what function that served. Sometimes secrets can be for a child, can be a really important way to take back some power in a system that I feel powerless in. So especially if I'm, as Lockie, as you mentioned, if I'm growing up in a system that maybe has some more extreme religious beliefs that our family is heavily ensconced in, that can be a way for me to take back some power that I engage in a behavior that I know is off limits. And I know I might be shamed or ostracized if I were to let people know about that. So exploring the initial experiences of secrets can be helpful. And if there is shame connected to sex, which for lots of people who might not be sex addicts, shame is also a part of sex. So I think it's a good question to ask is, when did shame first start to become part of the process or experience of sex? And how did you know it was shameful? What happened that communicated that to you? And I think maybe someone might have put something in the chat. I'm going to check that out. Great question. What is normal for masturbation? I have hold on one second. I'm going to get back to my presentation here so we can continue. So what is healthy masturbation is a great question to ask your clients. How do you define that for yourself? And what information are you drawing upon to reach that conclusion? My approach is to take that question and explore it with my client because I don't want to take this position that I am the moral authority on healthy sexuality, because I'm not. And the experience of masturbation and balance and in a quote healthy way is different for many people. I do my best to give kind of the basic non-negotiable, these are sort of some maybe obvious ways that masturbation might not be so healthy. What I'll say briefly is that for the vast majority of people, masturbation is a critical and lifelong important element of sexuality. It is a normative human behavior. Children know to, at some point, explore and experiment with masturbation without having any content or experience that mirrors that to them instinctually. we are driven towards pleasure, and there's nothing inherently wrong with self-pleasure. Typically for kids, it's best that they be given some instruction about how to maintain a level of privacy with masturbation so that they don't expose someone else to an unwanted sexual experience, and that they have a private space to explore their own sexuality. It's also best, again, for children, especially children younger than 16 who haven't completed puberty, to have that experience unencumbered by lots of pornography, so that they can actually have a connected bodily experience of pleasure that isn't contaminated with lots of imagery that potentially could be problematic for them or might engage more of an addictive pattern. So those are just some basics. Typically, healthy masturbation doesn't throw my life out of balance, doesn't hurt anyone, including myself, and doesn't lead to feelings of shame. Which in that last part can be more of an ongoing process of how someone is able to reclaim masturbation as a non-shameful activity for themselves, especially if they grew up in a more shaming system. I want to talk a little bit about on the onset of treatment. My experience has been that most people come in as a result of some kind of relational consequence. Their spouse or their partner finds out about their behavior and they protest it and they get into treatment. So for someone who is the partner of someone sex addicted or porn addicted, there's a couple important things to consider. This, again, is its own presentation. I'm not in any way going to be able to get into all the complexity of this, but I do want to acknowledge it because it's important. So if someone comes into my office with a sex or pornography addiction, I would like to include their partner in treatment as early as possible so we can reinforce the idea that we're all on the same team here, and that if there are things like infidelity or pornography use or financial betrayal that has been kept from them, that it's important that they get that information so they have context to be able to make a decision about who they want to be in relationship with. And so that's my bias in practice, is that people who have been betrayed sexually deserve to know the truth so that they can make an informed decision about who they're in relationship with. I've also found it to be most effective for the addicted person to have transparency, because without transparency, there's often going to be lots of shame still, because I'm not fully known. And that idea that if they really knew me or they really knew what I was up to, they wouldn't love me, is going to continue to erode the relationship if that's not disclosed. CSATs like myself, people who have been trained as a certified sex addiction therapist, get trained in something called formal disclosure. Formal disclosure is a 3-part process where the person who's been acting out writes out a full written history of what has been kept from the other person in the way of their sexual behavior or financial betrayal connected to that, or the gaslighting and deception that they have participated in to make sure that the other person didn't learn about the addiction. That full written history is then presented to their partner in a therapeutic setting with 2 therapists present to maintain as much therapeutic safety as possible in what is an inherently traumatizing event. The second part is something called an impact letter, which is the partner's opportunity to share with the addict the impact of the betrayal and the secrecy and the acting out on them and their life. And the idea is that this is a space for this partner who's been betrayed to really have their experience witnessed, because oftentimes they may have suffered in silence with this for many years. There's all kinds of layers to that, but it's super important that that they have a space to be able to get some healing for themselves in connection to how much harm has been caused to them. And then the last part of formal disclosure is something called a letter of restitution, which is an opportunity for the addicted person to be very clear about what is their ongoing commitment to treatment and recovery, and to engage empathy and move towards repair in the relationship as a result of the betrayal. That's a really difficult process for all people involved, but can be a really important pocket of healing for couples. Some other things to be aware of are if there's children involved, if there's been any kind of a disclosure about the behavior to the children, or if the children have discovered the addiction, super important that they get brought in and either are working with a family therapist, or that the parents are getting a lot of good coaching about how to interact with their kids, and disclose information to them that gives them context, but not so much detail that it creates imagery that's harmful. AKA, like they shouldn't be knowing ideally about the kinds of pornography that someone was looking at, because that's potentially going to be harmful to their relationship with them. But depending on the age of the child, it can be really helpful that they have some level of disclosure, so they have context for the kind of relational discord that's happening. There's a model called AppSats that I would highly recommend if you're interested in getting trained as a betrayal trauma specialist or working with partners of sex addicts. And the CSAT model also offers specialized training in that. I mentioned this a little bit earlier, but partners of sex addicts are likely to have experienced what's called staggered disclosure, which means they've made some kind of a discovery. Person left their phone around and they saw their search history, or they contracted an STD, or they looked at some text messages that didn't line up, and they got some information about the sex addiction, which probably prompts a confrontation. And typically what's going to happen is the addicted person is going to offer them a portion of the full story, and probably some level of avoidance or dismissiveness or gaslighting about the rest of the story. And that probably has happened repeatedly before they enter into treatment. Almost every time I work with sex addicted persons and I ask them, how much does your partner know? They'll say they know everything. And then when it comes time to actually write down what happened, there's very little. It's actually been disclosed to them, or just the tip of the iceberg. So the layer of deception and secrecy is usually pretty significant. That's an important piece of treatment to hit early. The other thing I would mention is that, again, interpersonal betrayal trauma, being betrayed and having broken trust with my partner, is sometimes the most devastating trauma that someone might experience. It completely erodes my perception of reality, completely erodes my sense of self, and oftentimes comes with devastating consequences across the board. As a result of that, a lot of partners of sex addicts present with a lot of PTSD symptomology early on. They're probably going to be heavily triggered by anything related to sex or betrayal. They're probably going to be pretty destabilized in terms of their sleep and their level of anxiety, and are likely going to be doing a lot of what we would call safety seeking, which is could look like, if out of context, might look like control of the other person, but it might be like, hey, I want to know, where you are at all times. I want to follow your location on your phone. I want you to send me pictures of everywhere you go. I want to know about any conversation you have with someone that in any way might stretch outside the bounds of our relationship, and et cetera. A lot of that are attempts to gain a sense of safety and control over their environment after they've been betrayed. And sometimes the intensity of their presentation can mirror what we might, have called borderline personality disorder. The reason I bring that up is just to be mindful of the context that oftentimes these partners are in an extreme crisis and have experienced, again, one of the most devastating traumas one can experience. So it's important to be mindful of that. This is a way to conceptualize treatment for a sex-addicted person. And this is not an exhaustive list, but it's just a way. It's like, okay, they walk in, we establish your meeting criteria for sex addiction. What do we do now? And I'll start here in the green, and then I'll go here to the yellow, and then here to the red. And that's kind of the sequence that I would encourage you all to follow or consider when treating this population. So sex addiction is a process addiction, which means that I am addicted to the entire process and series of behaviors around the sexual acting out. It's not just about the sex. So, and the goal is not to stop being sexual forever, right? It's different than other addictions. With a drug or alcohol addiction, if we're working an abstinence model, the goal is to not drink or use drugs again. That model isn't going to work with sex, because sex is a normal, natural behavior. I don't suggest that people stop having it altogether. And when someone comes in active addiction, their brain is in a compulsive state. When our brain is in a compulsive state, it reduces our ability to learn and integrate new information, and we probably don't feel calm enough to really integrate the benefits of therapy or the benefits of something like 12-step recovery or group therapy. So what is the going recommendation for sex addicts? is when they start treatment is to begin with a 90-day period of total abstinence from sex. And that includes masturbation and sex with other people. And what the intention of that 90-day window is to give their brain an opportunity to get out of a compulsive state and into a healing one. And so that they can start to integrate some of the benefits of therapy and 12-step recovery and the other things they might be doing. During that time, what you should expect is all of their unresolved emotional stuff to surface, because that's been the function of the addiction, is to keep that stuff clamped down. So during that period, they're much more likely to be able to have access to some of the things emotionally that have been underpinning the addiction. And then you all can deal with it, hopefully in a helpful way. Some other things that can be helpful to do in the early parts of treatment is to define what recovery is for them. So because we're talking about sex, everyone's sexual experiences and the context of their relationships are different. So recovery is going to look different for each individual. And in a moment, I'll show you a tool you can use to map out like what is recovery for this person. It's also important in the first stage of treatment to break through denial. That's our initial task as therapists with this person, is to help them break through the denial system that has allowed this addiction to continue for the time that it has. Some simple ways to do that is to start by having them list and explore directly the consequences directly connected to their sexual behavior, and to look at their secrets. So a common exercise that I'll ask people to engage in early treatment is I'll ask them to make a list of their secrets and who they're keeping them from, and bring that into session. The purpose of that is not to say, okay, great, now that we've identified all these secrets, let's go tell these people that you've been keeping them from. The purpose is to create a scenario where a person might be able to walk out of a room secret-free because they've at least told one person, in this case, you. And secrets are kind of our internal guardians against shame. I maintain my secrets so I don't have to feel the shame or humiliation that might happen if they were known. And so helping someone move beyond the life that their secrets have constructed can be a really helpful initial step in treatment, and is a good way to start to build trust. The goal with that exercise is just to have them be secret-free and be witnessed and moving out of their shame with another person. It's not necessarily to respond with a bunch of action initially. Like all addictions, group and the ability to be in a group and receive support from a group is crucial to long-term success. I don't have a particular bias about where people get that support, but it is critical that they get it. So there are a variety of 12-step fellowships for sex addiction. Those would be things like Sex Addicts Anonymous, Sexaholics Anonymous, Sex and Love Addicts Anonymous. There's also Pornography Addicts Anonymous. There's a variety of other fellowships that are more specific to porn. But it is crucial that people have those peer relationships with other people who struggle with the same problem, because those kinds of relationships are going to do a lot more to reduce the shame that they have about the behavior. And it's going to do a lot more to keep them accountable to a recovery process than you're going to be able to offer them one-on-one in therapy. So as we look here at the yellow part of the graph, improving affect regulation means that now that we've taken sex off the table, which is probably this person's primary way of dealing with life, we got to build in some other ways for them to navigate their internal state. And as much as possible, we want to emphasize that using other people that are safe and trustworthy is ideal. So if you have groups, whether it's a kind of interactive group therapy or you have a 12-step program you can recommend them to, that's ideal. There's also a decent amount of coaching programs online that might be done in group that are pretty, can be helpful. Coaching is kind of like therapy. It's not all created equal. There's some fantastic coaches that do a lot of great work, and there's some that don't, in the same way that there's lots of great therapists and others that might not have as much training or specialize. So getting folks in a group is really important. And then building in, during this 90-day period, people should expect to be really uncomfortable. So looking very closely at their relationship with exercise, their relationship with sleep, getting them engaged in some kind of a introspective practice of meditation or writing is going to be crucial during this phase of recovery. And then in this piece, this is kind of the longer term ongoing work, right? Is to start to peel back the layers of the trauma and the attachment injuries that have driven this behavior up to this point. And I'll go through a variety of different approaches to that. These are also, I've mentioned a couple of these already, but what I've found to be some pretty common treatment issues. There's definitely a theme with both male and female sex addicts that I've worked with, where when it comes to how they relate to their significant other, there's likely going to be a tremendous amount of conflict avoidance that is then acted out sexually. So, to give an example, it's like in my relationship, I might work really hard, and then I come home and I'm very caregiving and kind of passive in articulating what my needs are. I might kind of expect that my partner knows what my needs are and reads my mind, and maybe I kind of let them drive the relationship, and I'm not direct in addressing what it is that I need and want from them. And as a result of that, I grow resentful that I'm not getting my needs met. And then I act out sexually with other people as a means of resolving that anger that I feel towards them. Very common pattern with sex addicts, and rarely is it conscious. But it's important to highlight that and acknowledge it in treatment, because recovery is not just about stopping the acting out behavior. It's about finding ways to show up in my relationship as an adult, empowered in this moment to get my needs met and be attentive to this other person I find myself in relationship with. Being abstinent from sexual acting out and pornography is the bare minimum threshold that I have to establish first. It is by no means an end. It is a challenge at times to do this piece around balancing how do I work with this person on their trauma that I know and we know now drives this system and sets it up, and helping them stay accountable to a recovery process that's more focused on their addiction, and balancing how they're showing up in relationship to their partner who's highly traumatized and needs lots of repair from them. It's not easy. I try to conceptualize it as safety first. We want to keep both people, if it's a partnership, I want to keep both people safe as much as possible, establish boundaries and ground rules. Then we're going to get into recovery once we're plugged into recovery, and this person has a way to regulate some, and they can go into some of their traumatic material and not get lost in it. And they do that for a while and they get some balance. Then we're going to start the trauma work. And for the most part, that's how I try and approach it. So I talked earlier about how to define recovery for someone, and this is something called 3 circles. 3 circles is a tool that's used in a lot of S fellowships, a lot of 12-step programs for sex addiction. And it's pretty simple and straightforward. What the 3 circles are, the inner circle is what's called the abstinence list. And those are the behaviors that I want to take off the table completely. So that might be having sex with others, having sex with sex workers. It might be going to pornography bookstores, watching pornography. Those are the behaviors I'm taking off the table completely for now. The middle circle is kind of gray area, warning signs, cautionary things I might need to keep boundaries with so it doesn't move into inner circle behavior. The outer circle is a way to map out concretely what does health and balance, aka recovery, what does that look like for me? And it's best that this be as concrete as possible so that you and I and we all know we have transparency and clarity about what's recovery and what isn't. And with addicts that I work with, I want them to share this with their significant other if they have one. So they both have they can ask one question, which is, are you in recovery? Versus 10,000 questions to try and determine if there's more acting out happening. It's really helpful that there be clarity about that. This is a little more specific about what we would be putting in some of those areas. So Again, outer circle is what health and balance looks like. So that would include what health looks like sexually. So this is where in treatment we would help to define that with this person. So maybe they define, let me move this up so I can see all of what I've written here. Healthy sexuality for them might look like sex with their partner. It might include masturbation that doesn't involve secrets, which means if I masturbate, I let my significant other know. There's no secrets attached to that. Or if we masturbate, we do it together. A variety of those things could be true. In the outer circle, we also want to see those ways that this person is taking care of themselves, like with exercise, which might be, I make sure I get at least 30 minutes of exercise 3 times a week. So we want to make these things as concrete as possible. A middle circle behavior or a gray area might be things like I go multiple days without getting, what for me is optimal sleep. So maybe I go 3 days in a row getting less than 7.5 hours of sleep. Another to look at is someone's relationship with food. So what we know is that if our body goes too long without calories, if it goes too long without nutrients, and we stay hungry for too long, what happens is our serotonin levels in our brain get very low. When our serotonin levels get very low, our obsessional thinking increases, and folks who have addictions are likely to obsess about their acting out behaviors. So they're less likely to make good decisions if they've been hungry for too long. It might sound silly, but I recommend my clients don't do things like intermittent fasting for this particular reason while they're in this early stage of recovery. And again, the inner circle is going to be those behaviors that have caused harm or have become compulsive, and those are being taken off the table for now. All right, so that's a quick way to look at defining recovery. I want to pause here for just a second and see if there's any questions.
I had a question about you were talking about support groups for porn addiction, but what about for like teenagers or 13, 14, 15?
My experience has been if you can get those folks in a group with peers, that's better. The reality is if someone is 13 or 14, even if we look at those diagnostic criteria and they're meeting full criteria, that doesn't necessarily mean that they're going to have a porn or a sex addiction for the rest of their life, because they're in that stage of adolescence when some level of sexual compulsivity is fairly normal. So I found it to be more effective to get them into a group with their peers and probably that be a professionally led group. Again, because, adolescents at 13 or 14 are going to have less ability as peers to kind of keep the group structured enough. So that would be my suggestion. There are some CSATs that I know that conduct groups like that online. I don't know of any in particular that are happening that are sex addiction or porn addiction specific in Kentucky. But I do know of some happening online, which isn't ideal. I definitely prefer, especially for young people, that they be in groups with people in person. But and that's not to say that young people can't get benefits from 12-step programs, because they can.
Yeah, my only thought would be on groups with adolescents is they're not going to be like, okay, you can't tell anybody what you hear here. They're not going to be as mature about keeping secrets and stuff, I would think, in the community if they hear somebody else has got a problem.
Sure. Yeah, definitely a common issue in working with adolescents in treatment. And I would also acknowledge, even, having done a lot of groups with adults with, really robust ground rules around confidentiality, people still break the rules. But yeah, to your point, yeah, it's definitely more likely to happen with younger teens. Any other questions before we take another quick break? All right, folks, it is 10:32. So I'm going to get started here again. Did anyone think of another question while we were on break before I get started with the last segment here?
Mike, I have a question, and maybe I just want to know if you can speak to it for a moment. But when the outcome of the behaviors are attention from men, not necessarily sexual encounters with men. Is that still on the same spectrum? Is that something different? Sometimes it ends with sex, but not always. It's really the attention specifically from men.
Yeah, so that might fit more under the umbrella of like a love addiction or a sex and love addiction, or what some might call relationship compulsivity. So if the driver is really that attention or kind of affirmation that I get from another person who also there's some kind of a romantic or sexual interest in, but it doesn't necessarily involve sex, that the euphoria and the fantasy attached to the attention might be more the piece that's being sought after as opposed to sex. So, and if you look at addiction criteria and it's still having the same impact, or they have a similar relationship to that behavior, they would probably be more well suited to participate in something like a sex and love addiction program.
Awesome. Thank you.
Sure. While I'm on that subject, I would highly recommend some good books to explore. Would be things like Pia Melody's Facing Love Addiction. It's a great book that she talks about the overlap and overlay between sex and love addiction, but they are different. But that one will probably speak a little more specifically to someone who's, maybe, and that's not uncommon, work with people who they might have more emotional affairs or message with people online that doesn't actually involve any sexual contact, but is more based on like getting affirmation and attention.
Perfect.
Yeah, thank you for the question. Any others?
I have just a quick one, and I don't think you mentioned this in the beginning, but I might have missed it. Just in terms of like demographics between males and females who struggle with sexual addiction. I don't know if it's my own biases, but I'm thinking that it's more men. Just maybe that's just my experience. And I didn't know if you had those numbers and maybe like a brief explanation of potential causation for that.
Great question. I don't have specific numbers, and the reason I don't include them in here is the data I've reviewed. I don't think is conclusive enough to really put numbers to. But what I will say is that my experience has been that I see far more men than I do women. And just to own the kind of bias that I'm in, most of the cases I've worked have been heterosexual couples where the male is the addicted person and the female is the betrayed partner. And that's not to say there aren't female sex addicts, because there definitely are. It's all, and some factors for that is it's while sex addiction is still a heavily stigmatized area, it is far more stigmatized for women than it is for men because of some of the messaging around sex and pleasure that women receive as opposed to men. There's kind of the, cultural held belief that, men are sort of more animalistic and just pursue sex all the time. I think because of that skewed belief system, men are more willing to come forward and say they have sex addictions. Yeah. I would reference a couple people's work to answer the why question. There's a guy named Dr. Rob Weiss, who's also a CSAT and is an expert in this area. And he has some good content around the neuroscience related to how, for most males, and I'm going to generalize some things here, but for most males, there is an easier time separating sex from emotional connection. And there's also this piece called the Coolidge effect, which a guy named Gary Wilson explored in his research. He wrote a book called Your Brain on Porn. And the Coolidge effect is looking at how, as a species, males have evolved to increase their procreation potential by having sex with as many people as possible. And so there is some biology underneath this that I think sets men up potentially to be a little more vulnerable to developing sex addictions. What I'm seeing now that kind of is changing that some is the power of internet pornography in being able to influence young people. And I've seen more female sex addicts kind of in younger generations as a result of that. But that's that last thing I just said is purely anecdotal. Don't have research attached to it.
Okay, thank you so much.
Sure. All right. I'm going to keep it moving here. So this is an image that Carnes and his folks created. And basically what it is, it's a graphic way to show a process addiction. And what I like to do with it is I will take this image and give it to clients, and I'll have them use a poster or a large piece of paper to map out their addictive process. And I'll go through it quickly. On this top part, what we're really looking at is the emotional and mental processes that drive the addiction. Part of it is the belief system, and likely the belief system they have at the core is limiting and negative in some way, and is probably based out of their traumatic experiences or their dysfunctional family system. And maybe they have a belief like I'm not good enough, and that impairs my thinking in some way, where maybe as a result of feeling not good enough, I engage in relational sabotage behaviors that set me up to not feel good enough again. And some of those might be like what I mentioned earlier. I show up too passively with my partner and I don't tell them what I really need. And maybe I specifically don't tell them what I need sexually. And as a result of feeling neglected or like my needs aren't getting met by my partner, I grow resentful. And that resentment impairs my thinking and starts to drive this addictive cycle where I become preoccupied with the idea of sexual acting out in the variety of ways that I engage that in. What makes sex and porn a process addiction is that I get addicted to the ritual engaged in the behavior. So it's all the little things I do along the way that get me to that point of sexual euphoria. So for a porn addict, it's everything from part of my ritual could be when I hear the door shut and my partner leaves the house. That's my signal that I'm now alone. I'm going to go to the place in my house where I typically go to watch porn, and I'm going to pull my phone out of my pocket and I'm going to put my search browser in incognito mode on Google. All of those behaviors are part of the ritual, and all of those behaviors over time crank up the level of dopamine that I get in that experience. So the truth is I'm pretty high long before I ever actually engage anything erotic. And that's a way to map out process addiction. The goal with having a client write all this out in detail is it makes the pattern become predictable, and they're more likely to catch it and intervene sooner. I've talked a lot about group already. I just want to reemphasize that group is cutting edge treatment for addictions, and in my experiences, is oftentimes can be more helpful and beneficial than individual therapy. It's also a way for folks who are addicted to learn to use relationships non-compulsively and lean into things like vulnerability and empathy, as opposed to this very transactional way that sex addiction has us approach our relationships with others. I really like this work Carnes has done around, he calls them the core beliefs of addiction. And it's basically just a kind of a generalized set of beliefs that gets at the shame oftentimes that addicts might carry. And those are things like, I'm a flawed and unworthy person. If people really knew me, they wouldn't love me, which means I carry a mask or a facade around that prevents others from really seeing me from who I am. And likely my secrets contribute to this. My needs will never be met if I have to count on others. AKA, if I'm going to get my needs met, I got to do it on my own. I got to go outside the rules to get my needs met. And sex is my most important need, which is a kind of a landing place. Once the sexual behavior has kind of climbed that priority list of how I achieve dopamine, chances are everything else has become secondary to that, which includes my work, includes my relationships, includes my health. So these are belief systems that we want to address in treatment. And if I just print this out and hand it to a client and we talk about it and say, do any of these resonate with you? Is there any part of you that buys into this story about who you are? That can be a neat road directly into their wounds or directly into some of their trauma story. How did you start to believe that you were a flawed or unworthy person? If you're working with a client who's a little more avoidant, you might show them this list and they're like, no, I don't believe any of that. I'm fine. What I'll then want to do is I want to look at their behavior, and we'll just get curious together about if your behavior sent a message about what's true about you, what would it say? If your behavior could speak, what would it say? We'll start to explore that together, because oftentimes the behavior is a more accurate reflection of someone's inner state as opposed to their words. Very important to early on in the process to address shame for a variety of reasons. One is that shame is just a core driver of the addictive process. And the other is that from a relational standpoint, shame is a block to accountability. If you're working with an addict and they're deeply in their shame, when their partner confronts them about the impact of their behavior and how hurt they are, if they fall and collapse into shame, they're not going to be able to engage repair with them. So as early as possible, exploring how to build resilience to shame is crucial. And also helping educate clients about the function that shame serves, not just as this bad thing they want to get rid of, but why it gets there in the first place can be helpful. And this is this model of looking at shame is based more out of my training in working with folks who have a dissociative process and might have more complex trauma. And so I'll kind of walk you through it. Part of the function of shame is that shame is an unconscious way that I try and gain some control in a situation in which I have no power. So if I'm a 5-year-old and my dad works a lot and isn't around, I get very little experience with him in the moment, very little face-to-face interaction. If I really sit with the reality of that, I'm probably going to be met with a tremendous amount of sadness and loss about the lack of connection. And as a child, I don't have power over changing that situation. An unconscious movement to control that would be, it's not that my dad isn't around and I'm sad about that. It's that I'm actually a bad son and I'm not good enough. I can't compel him to want to be around me. AKA, if I were just better or different, this pain wouldn't exist in my life. So now I'm in this situation where I have internalized this situation I had powerlessness over and made it about me so that it feels like I can do something about it. Totally unconscious process for a child, but a clever way to stay away from some attachment pain. And what that helps me to do effectively is to stay away from this full realization. A full realization would be, I'm aware and in touch with my body and the impact that this experience has on my body, and I'm cognizant of how that affects my behavior. A realization might sound like there's an absence of my father in my life. I miss him. I don't have enough of him, and lacking his guidance prevents me from being able to grow into a full adult. That's the realization. And so shame helps me to derealize, to make that less real. And one way to do that is by focusing on how I'm the problem, not the situation itself. And so what addiction helps to do is it kind of helps to calcify that process. So I become fixated on how to keep secrets and how to stay away from my shame, which is a step away even from really feeling the pain of my own attachment loss. So I think it's helpful for people, especially addicts in treatment, is like when your partner confronts you, it's almost impossible to stay attuned to their experience and be empathetic towards them and be in your shame at the same time. I have yet to see a person who really does both. And so that's a way to help reorient them to what is needed in the moment. And then in therapy, we can start to hopefully slowly explore those parts of themselves and those experiences that have gotten lost in time or banished, that their shame has helped them to cover up. Again, practically speaking, a good way to start is to have them write a secrets list and start to explore in a narrative form the origins of their shame and how they first learned to become shameful. And ideally, over time, we can link that up with their sexual behavior and how sex became directly connected to the cycle of shame that they've probably been stuck in for a while. This is a kind of trauma work exercise. It's called the trauma egg. It was developed by a woman named Marilyn Murray. And it's sort of a quasi-narrative therapy, art therapy intervention that is also a pretty good assessment tool for trauma work, or something I found is helpful to do on the front end of doing some trauma work. So if you're trained in EMDR or somatic experiencing or IFS or one of these models that's more trauma specific, this can be an early stage intervention to get a sense of how dissociative someone is, or how much insight they have and being able to connect some of the themes of their trauma and how that connects to their current behavior, things like that. So the task with someone is they write down the unspoken family rules that they grew up in on the left. They write down what were their family roles, which might be the sort of stereotypical dysfunctional family roles like caretakers or scapegoat or mascot or hero. Could also be I was mom's counselor, or I was dad's girlfriend, or how they may have stepped into some different roles with different people. And then the left and the right, you do kind of a free association, write the first 5 words that come up when you think about your dad, first 5 words that come up when you think about your mom, which can be helpful in learning about the lens that they see men and women through, how that might affect who they act out sexually with, or how they see their partner. And in the middle, in those kind of overlapping pebbles that you see here, what you'll ask the client to do is to mark a symbol, not with words, but mark a symbol that represents a traumatic experience that they had, starting from as early as they can remember up until the current day, which would be up here. And so when you're finished, it'll look kind of something like this. And what you'll see in here is all these images that are just representations of a traumatic experience, and client can bring it into session and you can review that together. It's a nice way to not necessarily have a client have to go into the graphic details of the trauma, but more what it represents to them or what it means to them. What changed for you when this experience happened? And there's also some other benefits. It helps them to see all that they've survived. It can build in some resilience. I have found this to be an excellent group intervention. So if you're working with groups, you can take an hour and a half and explain this, have clients work on it, and then share in the group. They can get feedback on what others notice. But this can be a really helpful way to start to unpack, again, what might be some of the drivers of the addiction. In terms of affect regulation, something I like to start with is things that are a little more body-centric. I think I might have what we're learning and what I'm learning in some of the research I've looked at recently is that when it comes to things like meditation or mindfulness, in an effort to help someone change their internal state quickly, what has a little more effectiveness than just kind of traditional mindfulness is a structured respiration practice. A structured respiration practice would be anything from box breathing to the Wim Hof method to holotropic breath work. And the idea with a structured breathing practice is ideally what happens is my exhale repeatedly is longer than my inhale. So I might coach my client to say, hey, we're going to breathe in for 4 seconds. We're going to hold briefly, and then we're going to breathe out for 6 seconds. The numbers don't matter so much. What matters is that the exhale is longer than the inhale. When the exhale is longer than the inhale repeatedly, what's going to happen is my nervous system is going to send a signal to my brain that I'm not under threat, and it's okay that I go into rest and digest. And the more I do that, likely the more access I'm going to have to my prefrontal cortex and my thinking brain, and I can make better decisions. So with a sex addict who's in the early recovery, maybe they figured out that, hey, my use of social media is heavily connected to how I act out with others. So I'm going to take a break from all that. And 2 weeks in, I get this idea, hey, I think I'd like to get on Facebook and just see what people are up to. Even though Facebook has been a place where I get on Messenger and hit up people I used to go to high school with to have sexual conversations. So I'm going to ask that client, before you make a decision to re-download an app, I want you to spend 5 minutes doing this breathing exercise and then see if you want to make that same decision. If they're further along in recovery, I would even say something like, let's do 5 minutes of breathing like that and then call someone else in recovery and check that decision out and get some consultation before you begin doing that. I just wanted to share that mindfulness meditation is great. I really encourage a lot of my clients, or all of them really, to meditate in some way, but in the early stages to really change affect, a structured breathing practice seems to work better. And I'm conscious I'm moving through this stuff quickly. My goal is just to give some more kind of practical tools to use with people. And then at the end, I'll pause. And if there's questions you all have about how to implement this stuff, I'll stick around even a little bit after noon to answer those. And I want to be respectful of everyone's time. As soon as we hit noon, I will stop so you all can go on about your day. So if you're familiar at all with parts work, there's a host of different models that I think fall under the umbrella of parts work. The one that seems to be the most popular right now is internal family systems, but they don't have a monopoly on parts work by any means. There's a couple of different models like transactional analysis. There's ego state therapy. In essence, parts work is this idea that we are all made up of a variety of aspects of our internal self. And these different parts of us serve different functions, have different feelings, different motivations. And so with someone who's a sex or a pornography addict, when they present to treatment, there might be a part of them that is deeply remorseful and ashamed and sad about the harm that their behavior has caused to the people that they love the most, and they experience a great deal of helplessness about their problem. And there might be another part of them that has zero interest in changing and really enjoys the behavior and is very angry about being in therapy. That part, the second one, is the one that I would like to speak to and get in good relationship with at the beginning. So a simple way to approach that with folks is to ask, I'd love to talk to the part of you that doesn't want to be here. And I'd love to talk to the part of you that doesn't have any interest in stopping these behaviors that have led you to my office. And I want you to know that I have no interest in changing this part of who you are or getting rid of them. My goal is only to understand them more and to develop some trust together, because that is the part of them that will undermine their ability to succeed in recovery or therapy. And if you don't address it, it will manifest inevitably at some point. So it's really helpful, I found, for clients to normalize that experience so they feel a little more, they have a little more permission to bring it into session on purpose. Another piece to explore specifically is to look and talk to the part of them that drives them to act out sexually, and start to get curious about when they came online, how they benefit and keep this person safe, what they're trying to protect them from, and what their concern might happen if they really do stop and engage a whole new pattern of life. So those kind of parts work models, I think, can be really helpful in working with folks who have sex and pornography addictions. So this question came up earlier in a way. Somebody asked, like, what is healthy masturbation? And so again, I just would encourage you all not to take a position of being the moral authority on healthy sexuality, but helping your clients define that for themselves. These couple criteria I've thrown up, I found to be pretty good, basic non-negotiables for what healthy sexuality isn't. And my experience has been that healthy sexuality doesn't lead to feelings of shame. It doesn't diminish other areas of my life. It doesn't reduce balance. My life can have balance. I can be into other things and be sexual. It doesn't involve victims. No one is hurt. No, there's no non-consenting person who's hurt by my sexuality. And in this last part about being present is that I can actually be present in a sexual experience and embodied. That is often not the experience of sex addicts. You might learn as you explore this with your clients that oftentimes they might be heavily dissociated during the actual sexual experience. And the pleasure they experience from it might be much more in the anticipation or the fantasy associated rather than the actual bodily felt experience of it. A common one way to just give that some color, a common complaint that I hear from partners of someone who's a sex addict is that when it comes to the sex they have together, they feel like a masturbatory object. Like I am a person there in the experience, but they're not there with me. I am a means to an end for them, which again, for someone in an active addiction with sex, that's what sex is. It's a means to an end. Another way to explore this with someone is there's this concept of from a sexual belief standpoint, it's like what's called your sexual garden. And the idea is that as we grow, other people's ideas and the beliefs of our group or the beliefs of our religion or the culture we live in inserts messaging about what sex is and what sex means. And that the metaphor is that gets planted in our garden of what makes up our belief system of sex. it's helpful for people to map out and write about what that is for them, what they learned and who they learned it from. And then to ask the question, does this still fit for me? Does this way of thinking and viewing sex still serve me as an adult today? And if not, how would I like that to change? Sometimes it's easier to know what healthy sexuality isn't than to know what it is, and people can start to form and fashion their own idea from there. I want to reference a guy named Dr. Michael Bader's work. He wrote this book called Arousal, and in it, he presents a very non-judgmental way of viewing sexual fantasy and a whole variety of different sexual behaviors. And he kind of takes more of a psychodynamic approach to understanding why we're into what we're into. And for sex-addicted clients, I found his work to be helpful and given them a context that the role that and this is basically Bader's theory, which I found has good practical application. His theory is that sexual fantasy serves the role of resolving what might be pathological beliefs about me or about others that otherwise would get in the way of me being able to feel safe having sex and to take pleasure from having sex. So said simply, the fantasies that I create or the fantasies I pursue are ones where it's safe for me to take as much pleasure as possible and no one's going to get hurt. And therefore I can take as much selfishly, I can take as much pleasure from the moment as I would like to. And my fantasy will free me of what might be some negative beliefs about self that could get in the way of me having a positive sexual experience. And so, for example, someone might have a submission fetish or a submission fantasy where they enjoy being dominated or there being some element of power that's held over them during the sexual experience. What's possible is that may resolve some particular beliefs about me that get in the way of me enjoying sex, which could be that if the other person's in control, that means that they're getting their needs met and I don't have to worry about them. And it feels good for me to be free of the burden of responsibility for another, and I can just enjoy the experience for what it is. It's a simple example of how a fantasy could resolve a particular conflict internally. I'm going to skip through this. I talked a little earlier about an arousal template. I'll mention it briefly, and then I will close the presentation just talking about some suggested reading, and then I'll answer some questions. What an arousal template is it's everyone's a unique blueprint for what we find sexually interesting, arousing, and exciting. It's helpful in this process of addiction recovery to identify what that is for someone so that they can more consciously pursue what's genuinely interesting and arousing to them sexually, and they can integrate it into their life consciously, as opposed to maybe pursuing it in secret. A way to start to explore this is to have someone write out in graphic detail their most desired sexual fantasy, and giving them permission to explore that for whatever it might be. And in that writing, in the fantasy that sometimes people might have sort of a core fantasy they pursue, you'll learn some things likely about what they're into, and also how sex carries meaning for them, which is typically good insight for a person to have, not only in therapy, but just in general. And so I'm going to finish here, say goodbye to those of you who are going to step out. These are just some books and some materials that you can check out if you're interested in what I've shared today. Much of these materials is where I learned and who I got trained from. Facing the Shadow is a workbook that you can use with clients outside of therapy to address their sex addictive behaviors. Erotic Intelligence is this great book about how basically for sex addicts who are in recovery to re-engage healthy sex. And she gives some exercises that helps someone learn more about how to create a pattern of healthy sexuality for themselves. Your Brain on Porn is a really important text that Gary Wilson created as a result of a lot of research he's done about the brain. This is my go-to for people early in treatment from porn addiction because it really helps them see how the porn industry captures our attention and how it changes developmentally our experience of sex. These are also some books that I like to reference that help someone start to carve out what is healthy sexuality for me and how do I want to pursue that as an adult. Come As You Are is a great book that Emily Nagoski wrote. It's in some ways written more specifically for females, but she talks a lot about healthy sexuality from a broad spectrum, and I recommend it to clients often. Esther Perel's work I really like with anyone who's experienced intimate betrayal. It's helpful to understand the relational dynamics connected to affairs and intimate betrayal in a really kind of humanizing way. So I'm going to pull you all back up here, and I'm conscious that we're up to our time, and I really appreciate everyone being here. So if you need to step out, feel free to do so, and I'll stay around for a few more minutes and answer questions that you all have if you'd like to.
What about, sorry.
So real quick, I know you said we were gonna get the video of this, but would we have access to the slides as well, like in a PowerPoint?
Yes, I will send, after I finish today, I will send you all a PDF of all the slides.
Awesome. Thank you so much. That was great training. Appreciate it.
Excellent. Yeah, appreciate you being here and your questions.
What about the certificate or whatever that shows we got the credit hours?
Yes. So you'll get, you're going to get an email that's going to have access to a feedback survey for the presentation today. And then once that's completed, you'll get your CEU certificate that you can submit to your licensing board for your credit. If you have any issues getting that, please don't hesitate to text or email me, and I'll work with Hank to make sure you get that promptly. But you should get it automatically once you finish the survey. All right. Well, I appreciate everyone being here. I did forget to mention, just in case you're interested. Oh, I forgot to share my screen again. These are just some things that are coming up soon. If you're interested in any additional training, on the 29th, I'm going to be doing a training on intergenerational trauma and traumatic bonding. That'll be a 3-hour CEU event. On the 30th, I'm conducting a research study that's specific to helping parents recognize addictive screen behavior in their kids. If you or any of your clients might be interested in participating in that study, basically it's a couple of surveys and participating in a 2-hour educational training that's free. So feel free to shoot me an email if you or some of your clients might be interested in that. And then later in March, on the 29th, myself and a colleague named Ami Shah, who's a psychiatrist, will be presenting a training on cyberbullying and the social and emotional impact of that on teenagers. I do individual and group case consultation. So if you might have a sex addiction or porn addiction case you'd like to consult about, we can set something up to talk about that. Or if you're part of a group practice or have some other practitioners you think might be interested in that, we could also set up a group consultation. Sometimes it can be beneficial. We all kind of learn from each other, and cases usually have a lot of overlap. And anyways, so if you're interested in any of that, feel free to reach out to me anytime. And I really appreciate all of you showing up today. Any final questions before we close up?
Just going to say I appreciate it. Excellent training and information as always.
Awesome. And I will make sure you get that recording. All right. Well, you all take good care, and I will see you next time.